Hello and welcome to the Brain and Transcranial Photobiomodulation Virtual Summit. I'm your host, Dr. Joe Doduro, and my guest today is Dr. Greg Hipskind. He's a MD, PhD from St. Louis University. He's a behavioral and nuclear neurologist who's nationally recognized in the evaluation of traumatic brain injuries and carbon monoxide poisoning utilizing advanced quantitative nuclear brain imaging. He's certified as a brain injury specialist in 2010. He's a published expert in the evaluation of TBI using quantitative brain spec imaging as treatment using light therapy and photobiomodulation. He's considered one of the nation's leading forensic experts in advocating for the brain injured individual, and he's the president of Brain Injury Consulting LLC. We're very happy that he graduated from Notre Dame, which we like to say that. He's one of the first in the world to be qualified as a nuclear neurologist, and he's an expert in spec brain imaging being admitted into the courts for TBI so that he can make the invisible injuries visible to the juries. He's featured on Dr. Phil for his research in brain injury, and in 2015, he presented on Capitol Hill for National TBI Day. He was the only private practicing doctor to present in front of Congress. Thank you so much, Doc, for being here with us.
Thank you, Joe. Thank you for having me.
You've done so much work, so much expertise. You started your research back when you were, getting your MD degree, winning the Alpha Omega Alpha Research Award, and you've kind of been a trailblazer, the first one, and doing a lot of things. So how did you get to the point of, you were a clinical neurologist, you understood the brain, then you started to see the brain with your spec imaging, and then you started to get into interpret it in a different way. How did you get into your benefits of just seeing light therapy or photobiomodulation working on that? Give us a little background.
Yeah, just briefly, Joe, and I appreciate you having me. So my career basically started in primary neurology, and I ended up actually, this was in back in the 80s, and my main expertise at that time was an attention deficit hyperactivity disorder specialist, and I ended up seeing a large number of children and adolescents with ADHD, and then including adults initially. And in fact, I was on the National Advisory Committee for various pharmaceutical companies. I gave lectures around the country at that time. I published 5 articles on ADHD. But as that practice got more complicated, and this is a practice in north of Seattle, as I began getting referrals from the 5-state region, and I was getting more difficult and challenging cases with comorbid traumatic brain injury, cases with comorbid bipolar disorder, and other psychiatric illnesses. And I found at that time, this was by the mid-90s that this happened, and at that time, brain spec imaging actually in the late 80s, got a new isotope that made the images better. So I began incorporating brain spec imaging at my local community hospital with the help of my neuroradiologist there, and I would help him read the scans. He was kind enough to be willing to do the scans, and I would use the brain spec images to help sort out the difference between these various brain-based comorbidities, whether it was trauma, whether it was psychiatric, whether it was ADHD and the like. That's how I got started. It turns out that, and in fact, that was, I think you mentioned the Dr. Phil thing. I think that was one of the things that I was noted for at that time in the 90s, was that a lot of kids being diagnosed with ADD actually had childhood bipolar disorder. And you could see the difference between the two quite clearly on nuclear functional brain imaging. So that's how I started. But then it turns out that with the various Gulf Wars and so forth, increased awareness of traumatic brain injury, it turns out that functional brain imaging, such as SPECT and PET, was more sensitive to the cellular changes that occur in traumatic brain injury than anatomical imaging, such as CAT scans and MRIs. And that's when I began being requested to image brain injured patients who were functionally disabled from an apparent mild traumatic brain injury, and yet who had normal CT scans and MRIs. And lo and behold, when they went to functional imaging, we were actually able to see early on in the 90s and in the 2000s which became a very distinct pattern of traumatic brain injury. It's well, they're all different, but there's a core pattern that involves the frontal, temporal, and the limbic system. And this was published by several different authors. Aaron Bigler, the Brain Injury Association of America published a guide that showed where traumatic brain injury occurred, and so forth. And so we were able to demonstrate that. And then the next thing you know, and so for many years, my happiest day was when I was able to tell a brain injured patient that they actually had evidence of a brain injury, because they had injured their brains and they had done all this testing and they were disabled, they lost their jobs, they lost their marriages and so forth, and they were filing a claim, and the insurance company denied their claim of loss because of normal CAT scans and normal MRIs. And so their clinicians and the treating doctors and many of the neuropsychologists labeled them as malingerers and fakers. And so to get a procedure such as the one I do, and I'm not the only one doing them now, but to get a functional brain imaging study for a person like that that's been laboring for years under the false perception that they're faking their illness, to be able to tell them, I actually see evidence of your brain injury, they would cry with tears of happiness to be being told that they had evidence of a brain injury. So for many years, that was my happiest day. Fortunately, about 5 years ago, in my work with a brain imaging company, I came into contact with, I got involved with, shall we say, a study on veterans with traumatic brain injury using a relatively new modality, light therapy or photobiomodulation, and we ended up getting a grant from the Tug McGraw Foundation and performing quantitative brain SPECT imaging before and after intervention with transcranial photobiomodulation. And it turns out, and I guess that's what we're going to talk about today.
Sure, let's go to your slides. So we're going to look at these slides. Photobiomodulation therapy using LED improves cognition and cerebral blood flow in veterans with chronic TBI. Wow, this is exciting. Go ahead, Greg.
Okay, so as I was mentioning in my introduction about 5 years ago, and I think it's okay to mention the company, right, or not? Yep.
No, it's all right. Just a company.
Yeah, 5 years ago, I was working at a company called Hipskind in Denver, Colorado, a company which is on the cutting edge in brain SPECT imaging, and I've worked with them since, it's been the last 10 years. And I've worked with them both in performing the scan, obtaining them, advocating for brain injured patients in the courtroom, and also advancing and improving their software. So this study was done there with a grant from the Tug McGraw Foundation, in which we wanted to look at 12 brain injured veterans, and we wanted to use a light therapy device, a unique light therapy device for 20 minutes, 3 times a week for 6 weeks, and we did brain scans before and after. So we wanted to show the photobiomodulation using LEDs. Other people have shown it with lasers, have shown changes in SPECT with lasers, but we were the first to show it with LEDs. So just briefly, silent epidemic, don't spend too much time on this, but basically the point of this slide is that what some people consider what is actually officially diagnosed as a mild traumatic brain injury, and about 10% of cases ends up being a permanent brain injury. And so if you take, 2.8 million documented cases of TBI every year, of which about 80 to 85% are mild, and 10% of those go on to develop chronic problems. So it's just a large number of people. And a lot of people will get in an accident, get whiplash, and they work on their neck, their whiplash, and they get distracted by that, not realizing until months later that they've actually got cognitive problems. So this is that data that shows 10% or more of patients sustaining a mild TBI develop permanent brain damage. So as many as 400,000 to 500,000 new patients every year develop permanent brain damage from a mild TBI. And the point is that there's a lot of patients out there, we call them the miserable minority, waiting to be helped. Just what is a mild traumatic brain injury? It's basically the 2 points on this slide are, one, you do not have to strike your head. The injury can occur as a result of an acceleration or deceleration injury without actual physical trauma to the skull. And secondly, you don't have to be knocked out. Number one points out that any period of observed or self-reported transient confusion, disorientation, impaired consciousness, typical things you see in the emergency room charts. And the first complaints of patients, they were dazed, they were in a fog, they didn't know what time it was, etc. That is a symptom of a mild traumatic brain injury or synonymous with a concussion. Also, some reported loss of memory. So I'm not going to spend too much time on this because we're going to get into the meat. This is a graph, a timeline of PCS is post-concussive syndrome, and PPCS is persistent. And so as we talked about, from time zero is an accident or sustaining a mild traumatic brain injury, and the development of post-concussive syndrome. We'll discuss those symptoms in a second. That is, you get a headache, dizziness, and some things like that. In mild cases, 90% resolve before 6 months. Most of them actually before 3 months. But there's this so-called miserable minority of 10% that persist and end up with permanent brain damage. And a lot of these individuals, I've seen them clinically, they actually become disabled. They lose their jobs. They have personality changes, mood changes. They end up getting divorces, and they're in pretty bad shape. So this is the so-called miserable minority. So one of the things so the question is, why is it that some people can sustain a mild concussion and do just fine, and why is it that there's, even though it's a small percentage, a large number of people that persist? And the reason is that a lot of research has been done, as you know, on traumatic brain injury as a disease process. With the traumatic brain injury, cellular mechanisms are triggered that result in a cascading, a neurometabolic cascade that unfolds over time. It just isn't one thing that happened and it's over. And the worst is not necessarily always first. There are increases in depression and anxiety. And statistically, in undepressed patients, 1 year after a mild TBI, there's a 2.8 relative increase in depression. But these other processes that go on include neuroinflammation, and of course, as those of us in the photobiomodulation field know, and from research, we know that there's significant mitochondrial dysfunction that goes on in some patients after a mild TBI. So this is a complicated graph. The only thing to demonstrate is there's a significant change after, at time zero, a traumatic event. You see a big influx of calcium into the intracellular part of the cell, particularly the mitochondria. Changes in sodium, potassium, glutamate is increased, which is an neurotransmitter and can cause damage, actually. So there's a whole series of different metabolic events that occur initially, and these often can persist. When we look at what this looks like at the cellular level, what we have here in the upper right-hand corner is a neuron, and what we see in there in a special staining is the calcium that is accumulated inside the cell following a mild traumatic brain injury. And you can see how that would result and obliterate the mitochondria and obliterate the ability to produce ATP and continue that cell as a functioning entity. Other brain cells over here on the left show some vacuolization, complete loss of the brain cell as a result of this petrification. The next slide shows an axon. On this upper image, the little black dots represent the sodium-potassium pump. And you know the sodium-potassium pump is very key to brain cell activity. The sodium-potassium pump is what converts organic matter into an electrical conductor. And the way they do that is creating a dipole moment across that membrane, an electric charge, if you will. And that sodium-potassium pump consumes 20% of our resting energy in calories every day to maintain that membrane. So when this axon gets stretched, look what happens to the sodium-potassium pump. It gets displaced, and when the sodium-potassium pump gets displaced, it can't create a dipole moment anymore, and so this axon cannot conduct electricity. And if this axon is in some kind of connectome of, let's say, the memory circuit or the cognition or the attention circuit or whatever circuit in the brain you want to talk about, this axon down at the bottom here is not functioning as a result of disruption. So see some of the things that happen on a cellular level that are not necessarily visible with gross anatomic imaging. This is a case of a young man that was involved. This, fortunately, it's one of those cases where he had a pre-existing MRI prior to the injury, showing this normal sulci pattern, normal ventricle space here that looks like green beans in the middle. That's the lateral medial ventricles. And then this is the day of injury. You can see tremendous brain swelling, shrinkage of the ventricles with swelling of the brain parenchyma itself. This was the day of the injury. This is 1 day post-injury. Not a whole lot different. 7 days, you see you lost all the little sulci around the outside. 7 days later, you see a little bit shadows of improvement. A few of the sulci returning. 4 months later, you see swelling continuing to decrease, and now you see the ventricles returning to their almost normal shape. But if you compare these ventricles to these, you can see that they're enlarged. And ventricular enlargement is a sign of atrophy. And 2 years later, this individual ended up with anatomic changes as well. So this is good gross morphologic evidence of the fact that a traumatic brain injury is a disease process. These unfolded over a 2-year period. The next slide is my first case from 2003 of a lady that was involved in a motor vehicle accident. I'm showing this to demonstrate the difference between anatomic and functional imaging. On the day of the accident, she was struck. She was driving and she was broadsided from the left side, and she was taken. She did not lose consciousness, but she had sustained a mild traumatic brain injury. She had disorientation and some post-traumatic amnesia. She had some orthopedic injuries, shoulder injury, neck problems, but her brain CT was negative. And they basically sent her home and told her she'd probably have a headache for a few days, but that would get better. And by the way, telling someone that's had a mild concussion, a mild TBI, that they'll probably get better is not incorrect, because as we pointed out, 90% will. However, it's also important to tell them if you don't get better, you might want to look into it. She didn't get better. So 6 months later, she was still having headaches and symptoms of post-concussive syndrome and cognitive problems and thinking and problems and memory problems. So she went to a neurologist who obtained an MRI, and this was the MRI, and that was read as negative. And he told her there was basically nothing wrong with her, that whatever symptoms she was having was because she was depressed or whatever, I don't recall at the time, but they had no explanation for it. And so she continued for another year and a half to suffer with her symptoms of post-concussive syndrome. She was functionally disabled. She couldn't do the things that she needed to do. She couldn't remember anything. She needed family help. She finally came to us, and we did a brain spect on her, which this was as I look back on this, I think, well, this was the software developed by one of the world's experts at the time, Dr. Ismail Maina out of UCLA. And on his palettes, red represented normal blood flow. Yellow represented blood flow that was 2 standard deviations below normal, and he had a normal database with his software that you could compare it to. 2 standard deviations, green was 3 standard deviations, and blue is 4. So you can see there were significant areas of this woman's brain that were metabolically hypofunctioning and qualified as a traumatic brain injury. And she was able to go to court, and we were able to get her scans admitted and get her invisible injury. We were able to make it visible, get it before a judge, sustaining Daubert challenges, and so that the jury could see that in fact this woman was not malingering. So this is the role of functional brain imaging on what is a metabolic process. And the reason I want to emphasize the metabolic is because that's where photobiomodulation comes in later. I'm not going to go over this, but basically this basically shows that back as far as 3.5 billion years ago, this is a timeline on planet Earth. Organic matter was already interacting with the sun as early as 3.5 billion years ago. And then life sort of evolved, and as it evolved, mitochondria. I believe the first mitochondria came along a couple billion years ago, and then life proceeded to advance from there. Plants using photosynthesis, animals using mitochondria. So what is the mechanism of photobiomodulation? There's a lot of articles on that, a lot of research on it. This is just an overview, and I don't pretend to tell you everything that is known about photobiomodulation, except the general principles are that in the case of brain, near-infrared light has been shown to penetrate the skull. We know that happens with lasers, but it has also been demonstrated with non-coherent light. Lasers are coherent light therapy, which penetrates the skull in pinpoint fashion. In our study, we used LEDs, and each LED had a surface contact of 5 millimeters, and it generated 204 milliwatts per square centimeter of power density, which is pretty amazing. And numerous studies, both clinical and intraoperative, show that about 5% or so, anywhere from 3 to 5% of the near-infrared light will penetrate the skull and impinge on brain cells, which are located in the outer couple millimeters of the brain tissue. The red light red in the 620 to 650 nanometer. The NIR was in the 850 nanometer. Red, as most people know, penetrates to a lesser depth. It may warm the skin slightly to allow the NIR to penetrate deeper. There's a lot of discussion and theories about that. And blue, of course, only goes as far as the epidermis, maybe a little bit into the dermis. But the main mechanism is near-infrared light impinging on complex 4 cytochrome chromophore in mitochondria, copper-containing chromophore, which regulates the production of ATP. And what near-infrared light does is displaces nitric oxide from that complex, and this is what it's believed, and releasing respiration to advance more quickly and then produce more ATP. And again, we've seen why ATP is important. When a cell can produce more ATP, particularly a brain cell, it is better able to maintain that membrane potential. It is quite energy dependent. And so it doesn't take a lot of abnormalities or dysfunction of this mitochondria. A little bit of calcium on here that doesn't belong on here can significantly impair the brain cell's ability to create ATP and energy. So that's one thing that happens, increased ATP. The nitric oxide itself does a couple things. One of the things it does is it diffuses locally because of local vasodilation. And of course, that brings more oxygen and glucose to the brain cell to support respiration. And finally, the third big thing is that nitric oxide acts as an intracellular signaling in many studies to turn on the manufacturing of various healing substances, I'll call them. In various studies, depending on what you're looking at, there are natural anti-inflammatories, natural analgesics, natural antioxidants, glutathione, and various cell proliferative factors, growth factors such as BDNF, anti-apoptotic factor, and so forth. So that manufacture is triggered by the release of nitric oxide. This has been shown really beautifully in some of the animal models. And these substances can last as long as 3 or 4 weeks, at least in the mouse model. Of course, to make these things, it presumes that there are adequate precursors available in terms of amino acids, polysaccharides, cofactors, fatty acids, and trace minerals, which requires someone recovering from a traumatic brain injury to also pay attention to their diet, nutrition, and their supplements to enhance, to provide the proper substrates for the ability of your cell to respond to near-infrared light. So that is the proposed mechanism. This is a study done by Albert Young et al. This was we had an emitter here of near-infrared light and a detector on the right. And they were 40 millimeters apart. This was an intraoperative craniotomy, and as they peeled different layers of the skin, the dura, the skin, the galea, the skull, and then the dura. At each different level, they were able to measure as they peeled these layers off what percentage transmission occurred. And in this particular study, this was an in vivo behavior study of near-infrared light. They were able to demonstrate that, in fact, that this detector was detecting 5% or so of light beneath the skull and dura in a live patient. So we took in our study. So what we decided to do with all of this information, now that we know all about traumatic brain injury, the metabolic process involved, near-infrared light, how it actually works on the mitochondria and improves cellular function, we decided to do a study, and that study was we explored the outcome of applying near-infrared light using LEDs pulsed with 3 different frequencies transcranially to treat traumatic brain injury in veterans. We had 12 veterans. This device was very unique. Many near-infrared devices that are often published are present a continuous wave. In our case, we felt that pulsing at 3 different frequencies for 6.7 minutes during a 20-minute session each frequency would cover the possibility of one frequency being better than another frequency, because at this point, the general research shows by Hashmi, I believe it was 2006, that he did a review of continuous versus pulse light therapy, and it was our initial impression, and this may not hold up, but that pulsing light did a little bit better than continuous light. So we were able to locate a commercially available light emitting source that pulsed at 3 different frequencies. So as I've talked about, there are many studies showing that light therapy has been shown to have a positive effect on TBI. So we had 12 symptomatic military veterans diagnosed with chronic TBI 18 months after their trauma. This was important, and it wasn't done in other studies, because as a brain injury specialist, one of the things we know is that even though you may not return to normal in 6 months and you have persistent post-concussive syndrome, the brain cells you can still get some brain recovery up to 18 months. So we wanted to make sure that any natural healing had occurred prior to the application of our treatment. And we used 2 neoprene pads. We had 220 infrared, 180 red LEDs. The total power was 3.3 watts, with the average power density of 16.4 milliwatts per square centimeter. This is about half of what had been published previously, but we felt that the pulsing and the fact that the cylinder of each 5 millimeter 40 milliwatt NIR diode would compensate for the lack of total power. We did it for 20 minutes, 3 times a week for 6 weeks. I'd like to point out, thank you, give a shout out to Dr. Michael Hamblin for suggesting in my manuscript that I change 3 times per week to thrice per week. Not a word I would normally use. So you know that Hamblin was involved with this. Outcome measures, and by the way, he liked it. And outcome measures included, we did before and after standard neuropsychological tests, we did qualitative SPECT, and we also did quantitative SPECT, because we ended up, and I'll talk about that in a minute, using a quantitative software program that was different than our standard one we used every day at Hipskind to measure possible changes in brain blood flow. In other words, if your brain cells are working right, you're working right. And brain cells, the analogy is a working muscle at rest. There's a certain amount of blood flow. The more the muscle works, the more metabolic products it creates, and the increased blood flow it draws to itself. So you can tell in the brain, and there's about a 0.95 correlation between blood flow and metabolic activity as measured by PET. PET measures oxygen consumption and glucose utilization, and in studies comparing quantitative SPECT to PET, there's about a 0.93 to 0.95 correlation between the blood flow basically mimicking the metabolic activity. So, and SPECT is present in 10,000 hospitals across the country, whereas PET is not. It's much more expensive. It's less readily available. It's sometimes SPECT is sometimes referred to as the poor man's PET, but it's a good tool. These were the tests. These are the results of the neuropsychological testing. These were the tests we used and the sub-tests: California Verbal, pretty standard, Wechsler, the IQ test, trail making, and vigilance. These are the mean T-scores before treatment in this column, and these are the scores afterwards. Except for this very first one, The trial one of the California verbal went from 46 point, this is by the way grouped, this is a group mean of 12 individuals. Went from 46.3 to 45.3, went down. Every other subtest of the 15, all 14, if you look, they all improved across the board, 52 to 57, 51 to 55, 51.8 to 55, 49 to 54. This one 0.3, this one went up 2, this one went up 6. So 14 out of 15 neuropsychological subscales improved. And of those, and I think our picture may be in the way, they're on the right-hand side, but I had little stars. I don't know if we can move our picture.
No, I moved it. We can see them.
Oh, you can see them?
Yep.
That six of those scores increased statistically. So not only did people get better grossly, but they got better statistically, and in fact, clinically. They all reported improved symptoms, decreased headaches, increased concentration, decreased anxiety, improved memory, and so forth. So results were that the pulse transcranial photobiomodulation therapy significantly improved neuropsychological scores in 6 of 15 subscales, P less than 0.5 and two-tailed. And not mentioned here is the 14 out of 15 scales increased quantitatively, but not significantly. So this study looked at both neuropsychological testing, and we wanted to see if we could correlate the brain blood flow. So what you see here on the left, on the right, you have 4 brain images. The 2 images on the left, the lateral and the superior view, represent, this is one patient, and they weren't all this dramatic, but they were very similar. This is fairly representative. In the software, when we compare an individual's brain blood flow to 60 normal people, 64 normal people, wherever their brain blood flow is the same as normal, it shows up as gray. And wherever it was 95% below normal, it's green, 99% blue, and 97% blue and 99% black. As you can see, this individual had a significant amount of his brain that was under metabolic. And this same individual, I would like to point out, had a normal CT scan. This individual also was suicidal, suicidally depressed. He was a Ranger. He was a All-American hockey player, field hockey, or lacrosse, I guess. And just a super guy, military guy, special forces, bright guy, very athletic, and he was basically functionally disabled, and you can see why with this kind of brain. So we put light therapy on, and I thought I would put a picture of the device, but I guess I didn't. At any rate,
this is the first study to report this quantitative spec analysis of regional cerebral blood flow in regions of interest following pulse transcranial photobiomodulation in LEDs.
Correct. 8 out of 12. Actually, we saw so the results were that the blood flow increased in 8 out of 12, but actually it was 9. The other one only increased 4%, but for some reason we didn't include it. We just thought, well, maybe it's in the margin of error, but qualitatively increased. When we did the quantitative spec analysis, we had a significant, in that group that improved, we had a significant difference between pre and post treatment. What we did was we were able, with the bolt-on software, we were able to actually count individual gamma ray counts, because this is done, the isotope emits a gamma ray, and it's a gamma camera that detects the rays and produces the images. We were actually able to measure individual gamma rays per cubic centimeter of brain tissue, and they ranged, the degrees of freedom was 7 anyway. There was a difference of P007 before and after. And this is the first study of its kind that we are aware of to report quantitative SPECT changes in regions of interest following the use of pulsed transcranial photobiomodulation with LEDs. I think it's been known that lasers, there's a case report of a single patient in which a laser was used to increase brain blood flow, but even in that study, the blood flow was not quantified. So our conclusion was that transcranial photobiomodulation therapy using LEDs, I know there's a lot of laser guys out there, but LEDs show promise in improving cognitive function and brain blood flow years after TBI. Larger controlled studies are needed. So our opinion was that given the ease and convenience and ease of use and safety and home use of LEDs versus the increased expense and risk of injury and cost of laser therapy, that the use of LEDs for traumatic brain injury should be strongly considered, at least for more studies. I think the next study, if I was not retired now, would be a double-blind, sham-controlled study with larger numbers of patients. And we would also do some quantification of the depression and anxiety scales. We originally did a Likert scale, rating those symptoms of depression and anxiety 0 to 6. It was felt that that scale was not nationally validated. Those scales did show improvement in both depression and anxiety in this group, but the scale itself wasn't considered statistically valid enough, so we didn't publish that. But the fact is, all the patients involved in the study did report feeling better, better focusing, fewer headaches, and so forth, and less depression and anxiety. So where does this take us? Well, this is taken from a review article by Dr. Michael Hamblin. I'm sure a lot of you are aware of that. He lists, this is a list of brain disorders that may, in principle, be treated by transcranial photobiomodulation. In other words, some of them are in principle, and some have actually been shown in studies. For example, under traumatic column, we have acute stroke and chronic stroke. There was a phase 1 and a phase 2 study on stroke that showed that light therapy worked. When they got to the phase 3, it was equivocal whether it worked. Chronic stroke, acute TBI, chronic TBI. Ours was a study of chronic coma, birth trauma. So a lot of traumatic etiologies. Again, the common denominator in all of these disorders is pretty much the inability of brain cells to function normally, and usually the disease process of various types are impinging on the cell's ability to produce ATP. If a brain cell can produce ATP and maintain its membrane potential, it's going to work. And so many of these, whether it's in an inflammatory process, a toxic process, a metabolic process involving calcium, or whatever the final common pathway is, if you can get, given that NIR works on the mitochondria, the key, the lifeblood of the brain cell, you can see why he would list these things like Alzheimer's disease. There's articles published on its use with dementia and Parkinson's, some of these other conditions. Psychiatric diseases, several studies showing the use of Falcosano at Harvard has done studies with depression, actually with using one dose, one treatment, post-traumatic stress disorder, and then some of the neurodevelopmental disorders such as autism, ADHD. Getting back to my old friend ADHD. ADHD is a genetic condition, but in it, on the imaging, you see decreased metabolic activity in the frontal lobes, which is, of course, which are, of course, responsible for attention, focusing, and concentration. So theoretically, if you could increase the blood flow, well, you would increase the activity of the frontal lobes in ADHD individuals. So the summary is that mild TBI is highly prevalent. There are a lot of people that don't think they have one, but don't know why they're having problems. Loss of consciousness not required. It's a chronic TBI is a chronic disease process manifesting with mitochondrial dysfunction. Functional brain imaging, such as SPECT, and I would add PET, are more sensitive than anatomic imaging in diagnosing TBI. And finally, that photobiomodulation therapy improves the mitochondrial dysfunction of TBI and other brain disorders. And we could see that through the improved blood flow that's measured quantitatively on metabolic imaging. So with that, I thank everybody for listening in, and if you have any questions, you may call me. I got my number up there. I'm retired, and I'm happy to talk with people.
That's the bomb. Thank you, Doc. I mean, when
you have any questions? Do you have questions, or what do you want to do?
That's great. You did. I mean, thank you for sharing your expertise, and it's like a concert pianist, who has years and years of practice, who just can whip it out and play a symphony, a great symphony that you did a great job in explaining that to us. And I know from, many of us that will have never seen documentation like this, the neuroradiological documentation and the imaging, and to have you with your years of experience and expertise walk us through that. I think that's it's going to be a once in a lifetime event for many of the attendees. So thank you. Thank you so much.
You're welcome. Thanks for having me.
Now, we've looked back at your work of the past couple of decades. When we're from your seat now, if you turn forward, and we're doing it because your brain is working well, we're all together at the 2030 Brain and Transcranial Photobiomodulation Summit. I know you're going to be with us. What do you see how do you see this technology and this treatment evolving in 10 years?
Well, I think it will evolve. I will tell you bluntly, because the LEDs currently are a Class 2 device as cleared by the FDA, meaning that they're over-the-counter essentially, and they don't require a prescription from a medical doctor. Up until this point in time, they've been shown to be extremely safe and mostly effective. Not every study is a positive effect, but most of the studies for different conditions are getting positive results with light therapy. I think you're going to see a lot of pushback from the pharmaceutical industry. I don't think it's going to be easy to advance this. I think the science is there. I think hopefully people will continue to pursue it. For example, there's a lot, like the study that we did. I mean, the next step, if I was still doing, I would love to have like 1,000 patients and have a sham device and have a pre and post and double-blind, sham-controlled crossover study, with SPECT scans along the way and, at the crossover points and so forth. That would be, my fantasy as the field moves forward. And I think the next thing that's going to happen is finding out. I think there's something to the frequencies. Light is given, both laser and LEDs are often pulsed at different frequencies. And I think over time you're going to see research indicating that certain disease conditions are more amenable to pulsing than continuous. I think that's an area of research that needs to be worked out. So it's just a budding field for me. As I started this out by saying my happiest day was telling somebody they had brain damage, I now feel comfortable the last few years being exposed to light therapy through the InLight people. Basically, it was an InLight therapy device. Having been exposed to it through them, I'm thankful to them for that exposure. I'm now not only happy to tell them that I feel like they really do have a brain injury, but I'm even happier to tell them when they answer their next question, well, what do I do about it? So I think I'll close with that. It's been great to be able to have something to offer people with various brain disorders. And I was back in the 90s, maybe I'd be slapping some lights on my little ADD kids if they'd keep it on. Oops.